Hi everyone, your Optom coach this side, and today we'll be discussing the orbital apertures. So in this presentation, we'll be discussing various fissures and foramina that enter and exit the orbit. And these are the optic canal, the superior orbital fissure, both of which make the orbital apex, the inferior orbital fissure, the anterior and posterior ethmoidal foramen, zygomaticofacial and zygomaticotemporal foramina, and the nasolacrimal canal. So there are several foramina and fissures which exist between the orbit, the medial cranial fossa, sinuses and face, which allow the entrance and exit of vessels and nerves that supply the globe and the orbital structures. The main opening of the orbit is anteriorly and it is bounded by the orbital margin. I have already made a video on orbital margin. You guys can go and check it out. Coming to the apex of the orbit, it is the posterior end of the orbit where there are four orbital walls converge. Now, I just want to remind you that this can be asked as a separate question. So that is why I've covered it here. The apex has two orifices, the optic canal and the superior orbital fissure. Now, why is this so important? It is because the inflammation at the apex of the orbit, also known as Tolosa-Hunt syndrome, can result in ophthalmoplegia and venous outflow obstruction. Now this is because a lot of nerves and vessels pass through the orbital apex. We'll be discussing this in detail in the upcoming slides, but this is just a brief that it can cause like ophthalmoplegia and venous outflow obstruction. Optic canal, a funnel-shaped body channel in the sphenoid that passes anteriorly, inferiorly and laterally at a 36-degree angle from the middle cranial fossa to the apex of the orbit. It is formed by a bridge of bone called the optic strut, which is here, and which extends from the lesser wing of sphenoid to the sphenoid body. The canal is formed by two roots of the lesser wing of sphenoid. This can be asked as an MCQ. It connects the orbit to the middle cranial fossa. The canal lies just lateral to the body of sphenoid. The canal often causes an indentation into the bone of sphenoid. So this is the optic foramen and follows it an optic canal follows it. So the transmits the optic nerve along with its meninges, which is an extension of the subarachnoid space. So this is the optic nerve and the ophthalmic artery. So this is the optic canal and optic nerve and ophthalmic artery pass through it. Now ophthalmic artery lies below and then lateral to the nerve within the dural sheath for part of its course. Sympathetic nerve fibers accompany the artery. This is another important point. Normal adult dimensions of the optic canal are attained by the age of 4 to 5 years. Its average length is 6 to 11 millimeters. Lateral wall is shortest and medial wall is longest. The orbital end of the optic canal, that is optic foramen, is vertically oval and its dimension range from 6 mm into 4.5 mm. The center, however, is circular, 5 mm into 5 mm, and the cranial end is horizontally oval, 4.5 mm into 6 mm. The optic canals are 25 mm apart posteriorly and 30 mm anteriorly. Medial relations are sphenoidal and posterior ethmoidal air sinuses. Superior relations are olfactory tracts. Unilateral enlargement. Now this is an MCQ point of optic canal can be caused by tumors like optic nerve glioma and meningioma. So this enlargement can be seen on X-rays as well. And narrowing is seen in fibrous dysplasia. Blunt trauma to the optic canal can cause the fracture of optic canal and shearing of the pile vessels, which can eventually lead to optic atrophy. The second component of the orbital apex is the superior orbital fissure. Superior orbital fissure is a comma-shaped aperture in the orbital cavity lying between the lesser and greater wings of the sphenoid. It is about 22 mm long and it is a comma-shaped aperture. It connects the middle cranial fossa with the orbital cavity. It lies between the roof and lateral walls of the orbit. It is situated lateral to the optic foramen at the orbital apex. Lateral, okay. The optic strut formed by the inferior root of lesser wing of sphenoid separates it from the optic canal. We had discussed this before also. The fissure is usually the widest medially, becoming narrower towards the lateral portion. So we can see that this is wide here and it is becoming narrow on the lateral aspect. Approximately midway on the lower aspect is a small sharp spur, the lateral rectus spine, that serves as the attachment for the lateral rectus muscle. A circular band of connective tissue, the common tendinous ring, this is the common tendinous ring or annulus of Zinn, is located anterior to the fissure. Okay, so it is located anterior to the fissure and the optic canal. This ring is the origin of the 4 rectus muscles. The fissure is divided into an upper, middle and lower part by the common tendinous ring. So there is an upper part, a middle part and a lower part. The structures passing through the upper and lateral part are the lacrimal nerve, the frontal nerve, the trochlear nerve and the superior ophthalmic vein, which eventually drains into cavernous sinus. The middle part of the fissure, that is within the tendinous ring, this ring, thus within the apex of the muscle cone, transmits the superior and inferior division of the oculomotor nerve, the nasociliary nerve, which is branch of the ophthalmic division of trigeminal nerve, and the abducens nerve. The lower and the medial part of the fissure transmits the inferior ophthalmic vein, which is here. Okay. So these are the structures that pass through the superior orbital fissure, and superior orbital fissure itself can be asked as a short note. Now coming to the inferior orbital fissure, this fissure lies between the lateral wall and the floor and it separates the two of the orbit below the superior orbital fissure. So inferior orbital fissure lies below the superior orbital fissure between the lateral wall and the floor. It is bounded by the greater wing of sphenoid, maxilla and palatine bone. It forms a communication between the orbit and the infratemporal fossa and the pterygopalatine fossa. It runs forward and laterally for approximately 20 mm and ends 20 mm from the orbital margin. Infraorbital nerve carries sensation from the lower eyelid, cheek, upper lip, upper teeth and gingiva. The inferior orbital fissure is narrowest in the middle section and in life is covered by periorbita and a sheet of smooth muscle of unknown function, that is the muscle of Mueller's. It transmits the infraorbital nerve, zygomatic nerve, branch of pterygopalatine ganglion and inferior ophthalmic vein which drains into the pterygoid plexus. Now I would like to tell you the course of infraorbital nerve in brief. So maxillary nerve exits the skull through foramen rotundum and then reaches the pterygopalatine fossa and then the orbit in the infraorbital groove. It gives off a zygomatic branch which passes through the infraorbital fissure and is named infraorbital nerve, which exits through the infraorbital canal. Now the next foramen that we will be discussing is the zygomaticofacial and zygomaticotemporal foramen. These are small foramina that lie on the lateral wall of the orbit. So they lie at the lateral wall of the orbit. The zygomaticofacial foramen lies close to the junction of the lateral wall and floor and transmits the zygomaticofacial nerve, and the zygomaticotemporal foramen lies above the zygomaticofacial foramen close to the sphenozygomatic suture. it transmits the zygomaticotemporal nerve, which supplies the temporal fossa. So these are the zygomatic foramen, the zygomaticotemporal, and the zygomaticofacial. The anterior and posterior ethmoid foramen provide a potential route of entry into the orbit for pathogens and neoplasms from the sinuses. They also serve as a surgical landmark for superior extent of the medial wall surgery. Limiting manipulation of the medial orbital wall to the area below the level of these foramina helps prevent the inadvertent entry to the cranial vault. Damage to the medial wall above the level of the foramina may disrupt a plane superior to the cribriform plate. Now these transmit the nerves and arteries of the same name. So these are the anterior ethmoidal foramen and the posterior ethmoidal foramen. Coming to the nasolacrimal canal, the nasolacrimal canal extends inferiorly from the lacrimal fossa on the medial wall and terminates in the inferior nasal meatus. Now this is an MCQ point, that it terminates in the inferior nasal meatus beneath the inferior turbinate in the nasal cavity. It transmits the nasolacrimal duct, which continues from the lacrimal sac to the nasal mucosa. So this is all about the orbital fissures and foramens. For more such video, please subscribe to my channel. Thank you.